This is a patient, a 55-year-old female, never smoker, who presents to her primary care physician with a chronic cough and a 10-pound weight loss. The primary care physician orders a chest x-ray that reveals a very large opacity in the left upper lobe. The patient then has a CAT scan that reveals a 5-centimeter mass in the left upper lobe with bulky mediastinal lymphadenopathy. Following this, the patient does have an EBUS bronchoscopy that samples these mediastinal nodes, and the biopsy is consistent with a TTF1 positive, CK7 positive adenocarcinoma. The adenocarcinoma is sent for next-gen sequencing and is negative for all driver mutations, including EGFR, ALK, BRAF, and ROS, and the PDL1 by IHC is 0%. The patient then has a full staging brain MRI and PET-CT. The brain MRI reveals no intraparenchymal metastases, and the PET-CT confirms the left upper lobe, the mediastinal adenopathy, but also reveals a 4-centimeter adrenal metastases. This metastases is biopsied to confirm adenocarcinoma, which it is. Based on the fact the patient is a stage 4 adenocarcinoma, the patient and has no contraindications to anti-angiogenic strategies. The patient is started on carboplatin, pemetrexed, and bevacizumab. The patient receives 6 cycles of this triplet regimen and has a nice response, and then goes on to receive maintenance pemetrexed and bevacizumab for 9 more months. Unfortunately, at that time, the patient complains of worsening cough and further weight loss. A repeat CAT scan of the chest, abdomen, and pelvis shows that the tumor has enlarged in both the lung and the lymph nodes. The adrenal metastasis is also enlarged, and the patient has new liver mets. Based on this disease progression, the patient has been placed on atezolizumab, which she receives for up to 12 more months. It's important to note that young patients who do present with lung cancer unfortunately present with advanced stage disease. We're just not capturing most of these patients with early stage disease. Most of my young patients, particularly never smokers who do present with significant cough. Oftentimes they have bone pain from disease metastases to the bone, and unfortunately sometimes, specifically for patients that are EGFR or ALK rearranged, these patients can present with headaches and blurry vision, dizziness, and have brain metastases at the time of diagnoses. I think a lot of the times, many of the symptoms that younger never smoker patients have are ignored by their primary care physicians. Oftentimes, they'll be treated with several rounds of antibiotics before finally getting a chest CT and a biopsy because they're a never smoker. I think we need to remember that 20 to 25% of all non-small cell lung cancer is never smokers. And this is just not a fact that's well known by the primary care physicians and the pulmonologists. So I can't think of one time where I've had a young patient in their 50s, never smoker, or even 40s, where we've caught a stage 1 lung cancer. I think most of the time we're capturing these at a much later stage, unfortunately.